So, I think we get started. Please take a seat. You can really come to these places here, so they look very comfortable, so nobody has to stand behind. Bonjour, hello, good day. So it's a real pleasure to welcome everyone to this year's lunch symposium from Nestle on the ISICEM 2025 here in Brussels. It's such a really privilege to stand in front such a distinguished audience of clinicians, healthcare professionals, thought leaders to discuss the topic Unmasking the Silent Gut, Classifying Gastrointestinal Dysfunctions and its impact on the clinical outcomes of our patients. So the topic is really both. It is timely and profoundly important for the daily care of our patients on the ICU. And I'm looking forward to great discussions here. So, in fact, it's really that the gut still belongs to the mostly unforgotten, so-called unforgotten organs, which we are in the daily care of our patients, whereas it is anything but not, whereas it plays anything but a minor role. So the key functions are it regulates the immune functions in our bodies, our patients' bodies. So it's important to regulate the metabolic hemostasis and the microbiome. So both are very important to optimize our patients' antioxidant and anti-inflammatory and immune defense mechanisms. So further, it is known that it has some impact on the outcomes of our patients. So therefore, we really have to care about that. So if we do not care about that and our patients have really severe gastrointestinal dysfunctions, so then we know that it may impact the outcomes of our patients and it impacts the treatment in our patients. So it may prolong the ICU length of stay, lead to complications, and may increase the morbidity and mortality rates. So the pathophysiological underlying mechanisms are something about which I don't want to talk too much, but it's really important to take a deeper dive and to take a closer look into that. When considering the learnings of our recent large-scale multi-center RCTs, we are left with uncertainties about that, because when we consider the trials which have tested early nutritional interventions in our patients, and especially very early aggressive enteral feeding strategies, which have been tested, for example, in the calorie trials or in the Nutria 2 and 3 trial, it has been demonstrated that all of this led to longer time to discharge, more infectious complications, more mortality rates even in these patients that were randomized to a very intense aggressive feeding strategy. So let's take a closer look into the data and let's discuss this a little bit more. But I just want to bring this to your attention. When considering all available nutrition trials here over the past decades, even for parenteral and enteral nutrition, then it's very important to keep one thing in mind. So most of them, interestingly, were focusing on the very early acute phase. So the intervention really started in all of these on day 2, and most of the nutrition trials demonstrated that the targets were achieved on day 4. So it was a very intense, very aggressive strategy. And nothing really has been tested in these patients when the intervention was started, with a little delay in the post-acute phase, for example. So this is really an area which needs more consideration. But no feeding is as well no option, because we really know that if we do not feed our patients, this is obvious. This leads to significant loss of muscle mass. This really impacts the outcomes of our patients and may increase the infections rate. So these are the detrimental, the deleterious effects which we really try to avoid in our patients. So therefore, we have to think about how to enable more careful approaches for our patients, so more personalized approaches in our patients, and to think how, for example, a progressive feeding, which is currently recommended by our guidelines, can be realized in our patients. And we have as well to look like which nutritional strategies exist, what are signs, biological response mechanisms in our patients' bodies, and I'm very much looking forward to have great discussions during our next talks. And it's my great pleasure to invite our first speaker, Professor Vincent from Brussels, to give us the first lecture. Jean-Louis, thank you.
Thank you very much, my good friend. And indeed, it's a real pleasure to be here. The topic is very important, and I think deserves much more attention than we do today. But it's definitely not easy. Definitely not easy because this is really a silent threat. That's the title of my talk. I didn't choose it, but I like it. I think it's a very good title. And can we recognize GI dysfunction? I think the answer is yes and no. Yes, of course, as good clinicians, we could identify a number of signs and symptoms, perhaps even measure some elements, but not many. But it's not very precise. And therefore, we don't do it well, actually. Of course, we all have a conflict of interest here. We'd like to thank Nestlé. We received honoraria for these presentations. As we just heard, the gut has a very important role. Dysbiosis, altered epithelial function, increased gut permeability, translocation of bacteria and their products, impaired gut immunity, altered splanchnic perfusion. These are all very important elements. I will not have too much time to speak about dysbiosis because it's a topic by itself, especially if we speak about the microbiome. But this paper just came out, and it's a very good review in the Current Opinion. I am editor-in-chief of this journal. And it's very complex because we could speak about evenness, about diversity, about abundance. So there are different characteristics that could play an important role. And we know that we are just in the early stages of understanding the importance of the microbiome. Now, the other elements are somewhat intertwined. We speak about altered gut function associated with some reduced splanchnic perfusion in many conditions, and also the important role the gut plays in the immune response of the body. So, yeah, there is a complex interaction between the gut and all the other organs. If we think about it, that could be a talk by itself, to speak about the relation with the lung, with the brain, with the kidneys, etc. And that's how some people had this very important saying many years ago: the gut is a motor of multiple organ failure. So, as practicing clinicians, we should ask, what are the implications? And the first implication, as reviewed in this very recent paper, just published, is nutrition. That's the best thing we could do for the gut, to maintain its function, to maintain the flow, actually, with nutrition. Of course, we increase the flow going to the gut. And we could speak about probiotics, fecal microbiota transplantation, but we know that these things are very controversial, and we spoke about it this meeting and at many other meetings. And there are investigational strategies. But so what remains first is nutrition. And of course, when I was a young intensivist, we were saying, if the patient does not tolerate enteral feeding, you just go for parenteral nutrition and you are sure that everything is in the veins. But we reassessed it, not only because there are some risks associated with parenteral nutrition, but also because enteral nutrition plays a major role in maintaining gut function. So we agree that enteral nutrition should be preferred to parenteral nutrition to maintain gut function and also to avoid other risks associated with parenteral nutrition. So the recent guidelines here with a number of experts, some of them being in the room, the guidelines say that we should start low-dose enteral nutrition within 48 hours of ICU admission. What about patients in shock? Can I do that? Isn't there a risk of ischemia, bowel ischemia? Well, we can delay enteral nutrition in patients with shock, except perhaps if the vasopressor agents are administered in small, moderate doses. In patients requiring vasopressor agents, enteral nutrition should be started with gradual advancement, with monitoring for symptoms and signs of GI intolerance or unexplained worsening hemodynamic status. So it's some kind of yes and no, yes or no type of answer. Perhaps it's better to avoid it, but you can still do it, but prudently. And it shows again that we need to individualize our therapies, which is, of course, a theme that I always like to reinforce. So the question 10 in this paper was how to address GI intolerance. Well, it's usually with gastric residual volumes, GRVs. That's how we look at how much nutrition remains in the stomach. Of course, it's a marker of disease severity, but today it's a bit conflictual. Some people say we should not use it routinely, especially after a large study showing that it may not have a significant impact on outcome. Okay, that's not my topic. I will only go back to something we proposed, Jean-Charles Prézère and I, in the Lancet, well, 10 years ago, more than 10 years ago. But I think it's still valuable. It's still valid. If we can, we start enteral nutrition, maybe not in patients who will be starved for only a couple of days, but otherwise we would try to use the gut. Yeah. And if there is no good tolerance, after a few days we will start the parenteral nutrition. That's what we currently do. It's not a very precise recommendation, but that's what it is. It's also important to think at the splanchnic perfusion. When we think about it, almost 30% of our cardiac output goes to the splanchnic circulation. Wow! That's a large part of it, much more than the brain. And we must keep in mind that if we are in trouble, the first goal in life is to cope with bleeding. Our body reacts as if we had been hit by another animal and if we were bleeding, or if we had been traumatized for other reasons and we are bleeding. What happens then? We need to think at what we will do. So we need to preserve cerebral blood flow. We need to keep enough blood going to the heart to pump enough blood so the coronary blood flow is relatively preserved. But where can we get this blood? Well, we go in the splanchnic circulation. That's how when we are under stress, we are not hungry, we may have a little bit of diarrhea, we may have abdominal cramps before an exam when we are not ready for this exam. And of course, we need to reduce renal blood flow. That's smart. Because if we bleed, we don't want to urinate. We want to keep our volume. So that's the redistribution of blood flow. We need to think about it. And when we think at the various adrenergic agents, there is a risk of decreasing blood flow with vasopressors. Remember, we tried dopamine years ago with the idea that the dopaminergic receptors, which are vasodilating, are present more in the splanchnic circulation and in the renal circulation than elsewhere. So these are the dopaminergic effects of low-dose dopamine. Unfortunately, it didn't work very well in terms of patients' outcome. And with Daniel De Backer, when we did this prospective randomized control trial, we found that there was really no place for dopamine. Okay? So we have no good option to increase hepatosplanchnic blood flow. Certainly not vasopressin. Of course, vasopressin decreases hepatosplanchnic blood flow. It's a very interesting molecule, but don't use it for the gut. So, at the end, we are left with primarily beta-adrenergic agents, dobutamine, if we want to increase blood flow. But how will this be guided? That's not so easy. How can we assess GI dysfunction? Let's look at this recent paper, again with experts being among the authors. You can read it. Abdominal distension, bowel dilatation, abdominal pressure, abdominal pain, stool passage, vomiting. That's how we assess GI function, right? Not very precise. Not very objective. So we need some markers. And unfortunately, we don't have them. Citrulline is perhaps the marker at the top of the list, but it's not very good, not very reliable, no. So when we developed the SOFA score to describe organ dysfunction, when I was president of the European Society many years ago, we ultimately quantified the degree of organ dysfunction for 6 organs. We know that. And indeed, we wanted to have objective variables that we can easily measure everywhere. And there was a group in our working group. There was one group working on GI dysfunction. They came back and they said, sorry, we cannot propose anything. So that's the SOFA score with the 6 organs you know well, but there is nothing in GI dysfunction. So as you know, we are now in the process of revisiting the SOFA score. Okay, to add maybe vasopressin, to add maybe ECMO. Okay, I'm not sure these will be major changes, but in this process, we could not really better assess GI dysfunction. We are back to the same elements there. You could say, well, you can measure intra-abdominal pressure, that's important, instead of just saying that there is distension. Yeah. This has been known since 1947, before I was born, much before I was born. But the compartment syndrome is an interesting concept. But of course, the intra-abdominal pressure that we can measure quite easily, yes, indeed. Manneken Piss knows it well. It will concern a minority of patients, let's admit it. And then if the patient is treated like this, the abdominal pressure will go down, or like this, the abdominal pressure will go down. So, no, does not really work. Can we propose something else? When I was young, we were interested in gastric tonometry. You know, I spoke about it in this room 2 days ago. It's a modified nasogastric tube enabling to have some measurement of the oxygenation of the gastric mucosa. Oh, that's important. Oh, that's very, very important. And we had one study from South America published in The Lancet in 1992 showing that there could be a reduction in mortality if we try to maintain this pHi, the intramucosal pH, above a given value. Interesting. Yeah. No. Because there were too many artifacts. And especially feeding. Feeding was disturbing the measurement. So we threw it away. Unfortunately, we have no good variable to assess GI function. So, in summary, again, go back to these recent reviews here with Dr. Bachmann. You can read it, the clinical symptoms and signs, abdominal distension, absence of stool passage, abdominal pain, diarrhea, maybe GI bleeding if you want to include it there. Then we have the measurements, not much, and then you have the entities that could describe these abnormalities. It's very difficult to come up with a real score. So the clinical assessment remains the main tool, and a single sign and symptom does not reflect GI dysfunction adequately. So we need a set of variables, and even then, it's difficult to quantify it. So studies are warranted to develop tools reflecting GI motility, and biomarkers for response to enteral nutrients, including absorption. But right now, our approach is still very clinical, and the important element, again, is to try enteral feeding to protect the gut. Thank you very much.
Terrific. Thank you for this very, very nice presentation, Jean-Louis. Are there any quick questions? So we want to open the floor for really discussions after both talks, but if there are some urgent questions. So it may turn out that in the end, so I would call it the gut-brain axis, yeah, so that that we need the gut feeling and as well the brain to interpret all the signs, yeah, to manage really the nutrition support and to really make as well the gradual increase happen, which you have shown in your very nice publication together with Jean-Charles. Yeah? So I think we need this holistic approach. But are there any further comments on that? Questions? If this is not, you can still think about it. And I will introduce, meanwhile, the next speaker. It's my very, very, very pleasure to introduce Professor Elizabeth de Waele from Brussels as well, so who will give us further insights into this topic and maybe as well explain us how we can tackle the problems which we have discussed.
Thank you very much for the introduction, and thank you for Nestlé for enabling this. It was, of course, a great honor to be here and to talk together also with Professor Vincent. So how are we going to overcome those nutritional challenges and achieve better outcomes? Those are my disclosures. I would like first your attention for the fact that the reality does not always is the same as what we are talking about, as the studies are talking, the literature. You have been here for multiple days. This is the last day. Let's reflect on reality. And I show you some data on nutrition in ICUs. Those are ventilated patients. What you see here is the body weight of the patient, and you see body weight here and energy that we as intensivists and nurses and so are providing to the patients. This means, and you can look where you are, where your body weight is, and how much energy you might get. You might get nothing at all. You might get 3,000 kcal. So in practice, there is a large variability in what we are actually providing as nutrition to our patients. And normally, if you follow the recommendations of the European Society, for example, it would be that the higher the body weight, the more energy you would be getting. This is not the fact. You can say, okay, this is clinical data, we can do better. Well, I had the honor to contribute to the PRECISE study, which was published in The Lancet. And yes, we did. We achieved overall a good amount of energy to the patient. So we delivered a median of almost 25 kcal per kg per day on day 4. So you could say, you see that it's feasible because it is a trial setting, but it's the same patients. And of course, we were doing our clinical practice. But please, if you look at this, also have a look at this. Look at the whiskers of the plot. They go up and they go down. So also here you can see that the amount of energy that we are providing to our patients is apparently, at least to say, not depending on the body weight. So there's a huge variation in our clinical practice. So this is true for a lot of thousands of patients studied here on energy. What about protein? You have recommendations from all over the world. You have studies talking high protein and low and normal and standard, and what are those names? So let's say 0.8 and so on. But what is known from, once again, international data is that the average of our patients receive around 0.8 gram of kg of body weight per day. So way below the numbers that we are even discussing in our trials and our results. And this is real world. So let's go to expert centers. Well, This is a center of Professor Mette Berger in Switzerland, and she published it herself, so it's not that I'm showing her dirty laundry. What it shows is that there is an extreme variability of protein which is given to the patients. So even if we combine enteral with parenteral, you can see here the majority of the patients will get enteral nutrition. This is what we do. And then even then in those expert centers, 0.7. But on the other hand, she showed us that the ICU survivors had a higher protein intake than the ones that didn't survive in the Swiss data in her own center. And as you know, she has an extended experience in the field of nutrition in ICU. So this first part on energy and protein is just to show you that when you leave here today, and this is not the 6th floor, the panoramic, but it could be, if you take a moment before you rush back to reality, please wake up and think, what am I doing? What are we providing to our patients? Where are we? Do you know your data? Do you know what you're doing? So this is reality check. Now, if you want to improve your practice, if you want to do better than some of us, please get some guidance. And of course, you are interested in nutrition, theory, also the practice of having lunch, of course, but you have some guidance. The European Society can give you guidance on how to implement nutritional strategies and how to feed your patients. And also, of course, the American guidelines are available to read and to see how you can improve the numbers that we have seen before. 2 things. If you want to upgrade your nutritional therapy, you have technology helping you. Nutrition came a little bit back from having no biomarkers, but we do have some things. We have smart beds that can give you the body weight of the patient. And now that we give less fluids, the body weight might actually maybe represent your patient and not just a lot of edema. And those beds can get even smarter and tell you body composition. Body composition can be important for protein dosing maybe. We will learn from the Netherlands and other centers in the future. You also have, of course, the other devices. You can have, for example, indirect calorimetry to tell you how much energy your patient is consuming. You have very smart interfaces and software keeping track of how much enteral nutrition you are providing and how much that is in 24 hours. And of course, the ultrasound that we use for everything and everything in ICU. Maybe you can have a look at the stomach and see what's happening there, but you also look at muscle and other indirect indicators of nutritional feeding. So also there are opportunities of technology to help you. But you have technology, and as we have just seen by Professor Vincent, you can also go for clinical feeling and clinical parameters. And indeed, I would like to agree with him that some of them are not very numeric. You cannot really put a number on them. You can for abdominal pressure, but what about bowel dilatation, pain, scoring pain, how much is to be granted to the abdomen, yes or no? So these are the factors that you as a physician especially will take into consideration and bring it to your information cloud, to everything you know about your patient. And with that, you can adjust your protocol, you can leave the path of the guideline, and you can really individualize your patient. But we don't really know if this will lead to better outcomes, yes or no. So this is one. Here is a more practical one, which is also by Annika, a huge amount of work that has been done here. And here you already have a classification, which makes it for clinical practice interesting to say, okay, my patient apparently has a GI failure or a dysfunction, an increased risk, or it's even life-threatening. So then you actually have a number for this. And this kind of approaches make it also for research or for retrospective analysis quite interesting to know what is going on in that black box of the GI tract that your patient represents in ICU. So I would like to say another thing. What about the quality and the quantity of the nutrition that you are providing? I think this is the most important components of nutrition. And we have talked about this quantity. Here you can see it, European, American. You can say in the calorimetry, which is the golden standard. Otherwise, you use the body weight. And you can see that protein until now has been used in a body weight, and we will see for the future. So yes, you know what to do. The energy expenditure measurement still remains the #1 grade A recommendation to guide you on your energy. This is how it could look like. So you are in intensive care, you measure your patient. This is, of course, a corona setting. The plastic, it didn't help, but maybe in a psychological way it did. So you could measure and see that for a 41 BMI, you would have an energy expenditure of almost 2,400, and we really used it. So for the amount of nutrition, you need to have a plan, a calculation, a measurement. You need a plan. The other thing is that also for the quality of the food, you also need a strategy. What are you going to provide to your patients? What are you giving to your patients? This is what a human body needs to survive. So those are the components that you will find in enteral nutrition. If you are providing a high quality of parenteral nutrition, it will not have the fibers, of course, but all the rest will be there. So this is actually what your patient needs. So this is what we are providing. There's not such a big difference in the carbohydrates, but you know that in amino acids and lipids, there is a whole field of research and investigations how we can use the best or even to individualize the amino acids and the lipids to a certain profile of the patient. So this is interesting, the quality. And then I went a little bit back to this study, which was published by Professor Singer. Why do we actually have need of this protein? We have an intake, we have the amino acids converted into amino acids, and then you can see that these amino acids are used for several processes in the body. But we have been talking for so much time about feeding the muscle, you know, physical outcome, and I know it matters to patients to be able to walk, to be able to stand, to be able to have physical exercise. But please, be not misled by the circles, by the size of the circle, because if you put it in a right way, the intestine is the one that needs the amino acids, because this is a rapidly changing cell line. Think of your oncology patients. If you treat them with chemo, what's going to die first? Your arm, your muscle? No, your gut and your every cell line of the GI tract. So this is a rapidly changing cell line, and you need building blocks to give this to the patient so that he or she can rebuild their intestinal function and don't have the disadvantages that we have heard. So yes, muscle is important. Sorry, Professor Van Zanten, but apparently the gut might be more interesting and more interested in a quick delivery of the right amount and quality of proteins. So yes, we are still providing the proteins, and we are happy to confirm that this 1.3 gram of kJ per day might be a good idea, because we have tested extensively in this trial where we're comparing, let's say, the American approach to the European approach, or the 2.0 to the 1.3. And I'm happy to say here in Brussels that the European way was better than the American. It's maybe a nice time to tell that. So what you can see here, that's a personal note. So what you see here is that when you provide in real life in the study around 1.2 gram per kg per day with the same amount of calories, you had more happy patients. There was no mortality difference. And what was also interesting to see that when you go very high into the protein load, you got more GI symptoms. And I know from people who run a lot that the more the proteins, you cannot digest them in a very difficult time. So it's better not to overload, but please remember the 0.8. Don't underload, because then you will not make it to the finish neither. And what is interesting about those big trials is that now we know that we don't have to aim for these high ranges. But I'm always a little bit discomfortable, because when you are an individual patient, you might not benefit. And for example, we observed that it were especially the female patients who were not happy with a high protein load. And maybe this has to see with the different body composition, with the amount of muscle mass. This can be an explanation. So we have to learn from this data. But please, I don't think that finding the holy number of protein will actually be the future. I think individualizing and looking at phenotypes of patients would be much more interesting. It's also important, like I said, to not only think about the quality, the quantity, but also the quality. And research is being done on what a gut actually needs at a certain time point. There might be a higher need, for example, a whey protein or amino acids that are given by a different protein. So the quality, which protein we are providing, is something which is largely unknown. What does the body use? But therefore, I think it's very important to go to the latest generation and to learn from all the studies that we have been doing on quality of protein. So I would almost like to come to a conclusion and say that the variability in energy and protein feeding is really large. What you see, what you hear on the screens in the Congress are the future, and we'll learn to make clinicians better. But what we are actually doing now is largely underfeeding and overfeeding our patients. And when you get more prudent and when you don't want to overdo it, remember that you are probably underdoing it. A 0.8 is not a recommendation. So the reality of protein provision is not what we need. So please take that in mind when you go back to your ICUs. Also the energy, you're all different. You have other metabolisms. You have other energy expenditures. You also have an other energy need when you are in a critical state. So we have to respect these individual needs of energy. Let's be guided by guidelines. That's what we do in Brussels. That's what I tell my colleagues. You can learn so much. You can have new insights. But don't forget that you have a whole bunch of people, your colleagues, the nurses, the patients, the industry. Everybody needs to move, and they don't move so quickly. So when you have a new insight, it's nice. But in practice, sometimes it's safe just to stick to the guidelines until you have new guidance, because then you have to do a whole change program again, and you have to go through all the steps of implementing good care. So don't move too quickly and know what you're doing. Go for quantity and quality. I think that I stressed it out enough. So also please know what you're doing. If you have some kind of system, electronic medical system, if you design one yourself, you can monitor what you're doing, and then you know for your patients where you are in the blue cloud. Where are you? What are your patients receiving? This is data-based management, and in the field of nutrition, we need to do that. You actually can know what you're doing and act on it. Use new generation artificial nutrition. For some of us who have more experience, and even more experience and data was generated before I was born. So you have a lot of experience and use it and talk to people. The evolution of the products over the decades have had impact on the quality of the care and on the outcome of the patients. So also in the field, and we especially know it from the PN, but also in the enteral world, the better the products, the better the proteins that are more adjusted to the needs of the patients, probably the better you're feeding your patients. And enteral is always the first choice from a feeding perspective, from a patient perspective, from a healthcare economic perspective, from a safety perspective. So please use it, feed your patients well, and thank you for your attention.
Thank you so much, Elisabeth. This was a fantastic presentation. So the floor is open for a question. Jean-Louis, can I ask you to as well come back to the floor so that we can continue the discussion and exchanges here a bit? So are there any questions? If I can start with one, Elizabeth. You briefly talked or touched on the design of products, yeah. So, and at least I think it's really important to make the point, like, So based on the learnings which we have, which we received from last trials, we have to make clear that the products are even more than just energy. Yeah, so there's much more in, and we are treating patients which are admitted with already significant deficiencies. And we have to keep in mind that if we decide for example, permissive feeding or else, that our patients, that potential deficiencies may further aggravate. Yeah, so I think this is very, very, very important to keep this in mind. And this is really something which we cannot really put in guidelines. Can you comment on that?
I think, yes, the vitamin and the trace are close to your heart, I know, so of course we want to mention them. It is indeed true that we also want to provide vitamin and trace elements into the nutrition so that you're sure that you're feeding your patient. You need monitoring of plasma levels and so on, but I think that it's really important what you stress is that we have a complete nutrition and that you're actually providing everything the patient needs. So from a qualitative part, I agree with you that it needs to be a high quality of nutrition and also including vitamin and trace. And I think that is, like you say, we're not only fueling the patient with energy, we're also feeding the microbiome, for example, so that this homeostasis, this gut homeostasis, will have an action. And as we have heard, it is indeed a driving force. If the gut is healthy, the rest will probably be too. So I think that it's very important to stress that we are not only building the GI tract by providing building blocks, but also feeding our friends who live within the GI tract.
That's a nice summary. Yeah. Thank you. There's a question, yeah.
Yes, Frank Clifford from Germany. Professor Vincent taught us that we have no bedside tool for measuring the intestinal function. Maybe it's not a new idea, but is there an opportunity to measure it with radio-labeled nutrition components and measure it in the expiratory air? Is there some ideas to do that, or are there data on that?
Yeah, I'm not aware of that. There is still some investigation going in that direction. But, the analysis of expired gas or exhaled molecules has not really resulted in real practical implications yet. It's also true in the field of ARDS, for instance. In mechanically ventilated patients, you could sample the expired gas and try to do some analysis, and this has not really resulted in sound implications. So, do you have some information?
Well, there are some trials that indeed tell you that so that you can see what is actually incorporated and what is not, and that's very interesting. But I think there it's a matter of technology because this is, of course, not bedside available. It's more in study report. But we can get there. If we want to get there and technology can help, I think it would be really interesting also to see the evolution over time. Because maybe you want carbohydrates in the beginning, and then you would like some whey, and then you would like this amino acid at a certain time point of the disease. So from a real individualization also over time, I think this kind of immediate feedback would be very interesting, because up till now, it's really limited on what we know. We don't even know the absorption rate of the nutrition that we're giving. Yeah. You don't assess the stools regularly to know what is absorbed and what is not absorbed. Also, you can do it with bomb calorimetry. So it's interesting to learn what is actually happening in one patient so that you know the return on investment of your nutrition, and that in the end you would be able to change the formula to the phenotype or to the needs of the patient at one individual point. But we are not there yet, but it's a good suggestion to look into that direction, yes.
Do you think so? Beyond investigation to understand what the needs may be for this type of particular patients, do you think that in the future we will really look at exhaled substances to guide nutritional?
It could be a route. Of course, it's challenging because, as always in intensive care and other disease states, you don't know by observing if you're going to change, if you will intervene, if it will immediately have a better outcome. But at least we will learn to see what is actually happening and understand the GI function of a critically ill. And then we can base interventions and interventional trials, and the ones who are born now will maybe finish this. But it would be nice to have this in some aspects, yes.
So for the protein metabolism, just to add that, we have the fantastic work of Leanne Chappell, published in the Blue Journal, who showed that it's taken up but not metabolized. Yeah, and because the patients are probably too sick. Yeah, and this brings us back to another point, like when the timing really matters. And we have to talk about this after your comment on that.
The next remark is we have problems to measure the calorie demands from the patient. So why don't we implement CO2 measurement in the expiratory ventilator and measure it online? That would be a good approach and easy to... That's our main problem in the ICU setting, that we don't have realistic data online.
This was our demo box of this morning, where we were talking about VO2 and VCO2. So it would be another opportunity to talk about it. But you have it in your ventilators. You can know VCO2. You can multiply it by 8.19. Then you already have a value. And if you really want to know, you measure by indirect calorimetry VO2, VCO2. Put it in the WHERE equation, and you have a number. That's a different topic, I would say tomorrow, but that's not possible this morning, so maybe you can have a relook at this data.
But that's a slightly different question.
Yes.
You are now focusing on the amount of calories that we could give to the patient, the amount of calories that would be optimal. And that's sound, as long as we can indeed measure the VO2 and the CO2 production, that could potentially guide the amount of calories we give.
Yes, we have a... Yeah.
Yes, thank you for both for the excellent presentation. I'm a little bit concerned about the results of recent studies that maybe hypercaloric feeding is as good as normal feeding or full feeding, and that this extremely high protein doses come with a price. So lower quality of life, maybe a higher risk of mortality in some subgroups of patients. But we have to understand, if you look at the PRECISE trial group, we used catch-up feeding. So when the moment when the patient was a little bit behind, we added more feeding. So we were very well going to the targets in these very good nutrition hospitals in this trial. If you look at other data, for instance from Nutrition Day, we know that the performance of feeding is very poor in many ICUs. So it's my fear that based on these results, people think proteins are not important. Energy is not important. So don't give them anything or a very low dose, or don't bother about feeding. So the response will always be that the intake will be lower in the future. But we have to consider that those sites in these trials did a really good job of going to the targets. And the low group in the PRECISE trial heading 1.2 gram per kilogram per day of proteins is probably a high group in any other study. So we have to consider that. And I want maybe your comments about this, that we shouldn't go for like extremely low intakes of energy and proteins in the future, because, well, that will not be beneficial for our patients.
That's the message I gave with the Wake Up to Reality, and this is especially for the audience indeed, and also for us experts in nutrition. We are very worried because it might that the word goes, and it's already going, like you say, that you have to feed less and less, but we are already feeding less. So I totally agree that if you are an ARDS or you're in pain or you're an ECMO person, please don't go lower. Look at your own data, see where you are, and then be careful and maybe just stick to the 1.3 and for the protein at 20, because the message that is coming out is probably not something that you should implement immediately in your practice if you don't have your own data. If you don't know what you're doing, if you don't have your own data, please be very careful. So thank you I totally agree with you, Arthur. This is an important message.
And this brings a more general discussion about these prospective randomized control trials on heterogeneous patient populations. And you test only one particular regimen in a very heterogeneous population, and then you say, there is no difference in mortality. Wow. And we discussed it with Christian Stopper, who has very good ideas about this. We should definitely try to have trials using different protocols in well-defined patient populations, and perhaps we should have platform trials in the future where we could test different strategies and see which ones are really beneficial. Christian, if I may send the microphone to you.
Thank you. Yeah, together with Emma Ridley, who's as well here, and we really try to keep all people who are working in this area, and I encourage you really to come after the session to us to really talk with us as group together about like how can we really emphasize the findings and really how can we make it better, so that we identify new strategies for our patients. I think with your first talk we come to the point actually that more nuanced approaches, more tailored approaches are really necessary. So to make it happen, we really need another strategy to design such clinical trials, not A versus B. We really need successive and parallel testings, etc., to think about what is the best for our patients.
Yes, because when I end up in intensive care, I hope not. I mean, I don't want to be fed like a BMI 27 man. I want to be fed as my profile, because this is what you say. The population is not, you are not representing the population. So I agree with you that platform trials or adaptive trial designs, that we need other trials designs to investigate this individualized approach.
So, and I also liked your slide, your graph, which is really very good, where you show that virtually all trials focused on the very first days of the disease state. But many of our patients stay quite for a long time in the ICU or in the hospital. And people think that by changing a little bit something in the first day, they will decrease mortality. But that's not reasonable. So we need to have also data collection beyond the first 2-3 days. Yeah. I think it's fundamentally important. And as you say, maybe things will change over time. And so we need to change our strategy for early versus later phases. And this is not just based on timing. It's not the first 48 hours, the first 72 hours. No, we need to characterize the stage of any single individual. So for some patients, it would be just the first day, which would be different from the rest. For others, it would be 3 days. Think of the duration of shock. I mean, it's not just 12 hours in every single patient. It can be longer. It can be shorter. So, again, individualization.
And also, like you say, the timing, we know from data, we have our own data, other data is available. The day your patient leaves the ICU, and it was Professor Presser who said, critical illness is a disease state, not a location in the hospital. Yeah. When you go from the intensive care to the ward, we know that the nutritional adequacy drops by 20% because you have less nurses and less dietitians. It drops by 20 to 30% one day from the other. There is a huge opportunity for treatment over there. And you know from data that it's not happening. We published a systematic review meta-analysis. It's worse than ICU. So we have to stop fighting on day 2 and day 3, like you say, and see the opportunities of adequate feeding. And we need to define what is adequate feeding in a later stage or in a post-ICU stage. And we will do that in the future. But there is a huge treatment opportunity for our patients once they have survived those first days of critical illness. And then think on a positive note, this is something really where we can make a difference for our patients.
Mm-hmm. So when we were discussing together with Emma, Elizabeth, Arthur, and all the other international wonderful colleagues these problems, we were just thinking, okay, we don't like days, but how can we change the system? And this is really a major problem which we try to tackle. Yeah, and I think this is important for research, but as well for the clinical practice. And I just want to bring the discussion a bit more like as well in the direction. How can we judge that the patient is transitioning from a very acute phase to another, maybe later acute phase, so that we might feel encouraged to start or ramp up enteral feeding so that we have good markers. And therefore, I really liked that you showed in your first presentation like all the different approaches which can inform us about like, oh, we feel better to increase, ramp up enteral feeding. And what are your thoughts about the SOFA score, Jean-Louis? I think because it really captures nicely different organ functions. Or Elizabeth, what are your thoughts? Can this help us to guide our enteral feeding strategy or nutrition support?
Yeah, though that would also be relatively rough. The SOFA score is helpful for patient populations, but not for an individual patient. You don't want to calculate the SOFA score of your patient every day. We don't in Brussels. We don't calculate the SOFA score. It could be obtained automatically, of course, from the computerized system. But what do we do with it? What do we know? What does it imply that the SOFA score is at 4 or 5 or 6 or 7? Not really. So we prefer to think at the various organ dysfunctions, but a score will not really help.
No, when the delta so far. So when it's decreasing, so this could encourage you.
Well, yeah, but that's the same thing as saying my patient is improving. Yeah. That's the SOFA score going down. Or my patient is getting worse. That's the SOFA score going up. Okay, you quantify that clinical impression. But you are right to stress that the patients do not have a linear evolution. And that's how we selected this talk during the opening session about the trajectories. Because when we speak about nutrition, it often goes like this and like this. But there are many patients who go like this, okay? And there is a relapse, and there is now a nosocomial infection, and there is a complication. So the patients do not behave like a straight line or a straight curve. It's sometimes much more complex, right?
Yes, of course, and this is why we need to lose the days and get really into patient-specific. What I would also like to ask maybe opinion of you or other people is about this, keeping the gut healthy and providing building blocks for the gut. As we have seen that they use 40% of the amino acids. How can we know if the feeding is a burden or a pleasure for the gut at a certain time point? Is it just like trying to work it away, or is it actually something that is helping the gut at a certain time point? And this feedback would be very nice. And Annika Rent-Blaser said it on Monday. We should sometimes be careful when you're feeding a gut which is not in a good condition. I've done the surgery long times ago where you see the gut not functioning at all, and then there is nutrition inside, and nothing's going to happen. So we need to really know, is the gut feeling happy, yes or no? And can we use it, and how can we maybe help it to be more happy and more functional? So it's true that it's still quite a black box, but we have to open the box and invest also in research to know what is a good moment to give the nutrition, yes or no.
So do you and the other experts in the room have some suggestions for things we could measure to assess that? Do you think citrulline or the other biomarkers that I cited, do you think that will really help? That's maybe for Arthur.
Is it working?
Yes.
Yeah.
Okay. Well, there are a few options. You could look at insulin to glucose, whether the insulin levels are very high, but it's rather a specific. We look now to the biomarker urea-creatinine ratio to see. And it's interesting what you said about the SOFA scores, or we looked at CRP. One of the problems is the dynamics of SOFA and CRP can be very quickly. So you see resolving organ failure. But we found in some patients that the UCR keeps on elevated for 10 to 14 days, suggesting that still those patients are not able to handle the proteins very well. It's anabolic resistance. So maybe the interaction between immune system and metabolism can lead to prolonged disruptions in the functioning of the metabolism longer than maybe depicted by SOFA scores or CRP. It's difficult. And one last comment. We have the large high protein studies, and we know now that the absorption from the study Christian alluded to from Australia, the absorption of protein is rather okay, meaning that when you give too much, you will overload the patients. It will be absorbed. There seems not to be a defense in the absorption in the gut to prevent high protein intake. It's just absorbed if you take it in. But it cannot be handled. So I think for us it leads to the concept that we have to prevent protein or energy overfeeding, but we lack biomarkers from a perspective of endotyping the metabolism. But maybe in the future we'll find a few. I think UCR is one of the most promising and easy ones to do at the bedside now.
Aside from the fancy stuff, you can also look at the stools, because the stools is what's coming out. And if there is a huge amount of energy and undigested food still in the stools, then it's not in the patient. So I think this is also an interesting, quite smelly way of research, but it can be interesting and it's really available. And this could be also an interesting part.
Yeah.
There's one last question. Sorry, we have to keep it brief, please.
Sorry. I was wondering if there is any data on the feeling of hunger, like told by the patient by the time he's recovering, because most of the patients, they are like neurologically not really reliable, but still they say they're hungry. So if there's any reliability in that.
Yes, there is data from Nutrition Day, and we've been participating for, I think, more than 10 years. The patients who are able to respond in intensive care are quite in the middle. Are you feeling hungry, yes or no? It's, as I remember well, not very outspoken yes, but some of them are and some of them are not, as in the most data that we collect. But from a post-ICU perspective, a lot of patients are really, really hungry. So when they're able to swallow, when they're in a good mental state, you hear it a lot, and that's more clinical experience, that patients are really hungry after this acute phase. And it's also really important because, of course, this can be a good guidance too, if you can just listen to the patient and see what the patient is feeling. So thank you for the question. In Nutrition Day, you can find the hard data back. Yes.
So we have unfortunately to come to an end. Yeah. So thank you so much for all your commitment, engagement, curiosity to really try to improve the outcomes of our patients. Thanks to the speakers. Thanks to Nestle and to the ISICEM to bring us together. I'm looking forward to continue these discussions after the session. Thank you.
Thank you.
Very good. Thank you. And I love your dress. It's very nice the way you dress.
Thank you. It's